Barrett's is the only known precursor for esophageal adenocarcinoma, and the risk factors for Barrett's and esophageal adenocarcinoma, or EAC, are the same. Among those with Barrett's, the risk of progressing to cancer is around 0.5% per year, so about 5% per decade. So 95% of patients with Barrett's do not progress to cancer over the course of a decade. But it's the most important risk factor we know of for esophageal adenocarcinoma. Well, for the most part, it mostly reinforces prior guidelines in terms of our main recommendations. There are differences in the nuance of how we address managing low-grade dysplasia, and our recommendation regarding which form of endoscopic resection that we should use differs slightly from some prior guidance from some other societies. But in addition, we made a number of new implementation statements, which are based on more expert opinion than the high-quality evidence that our main recommendation statements are based on, because that evidence is primarily lacking in those areas. And examples of those sorts of implementation statements are counseling patients with Barrett's about tobacco cessation and losing weight if they're overweight, referral of patients with dysplastic Barrett's to endoscopists who are experts in endoscopic eradication therapy, and also pathologists with expertise in Barrett's neoplasia. We make comments about the optimization of acid reflux control before undergoing endoscopic eradication therapy, which has not really been addressed much by prior guidance. And then also optimal discussion with patients about the risks and benefits of endoscopic eradication therapy, the need for adherence with reflux control, continued surveillance after completion of endoscopic eradication therapy, and assessing patient preferences before undergoing endoscopic therapy. We also provide specific guidance for what the endoscopic and histologic endpoint we should be aiming for with endoscopic eradication therapy, what that should be. And we give some guidance that's changed slightly from prior guidance about what the surveillance intervals following completion of endoscopic eradication therapy should be. In high-grade dysplasia, there's a risk of a prevalent missed cancer of roughly 30%, but also even in the absence of prevalent cancer, the incidence of new cancer is about 6% per year, as opposed to the 5% per decade in non-dysplastic Barrett's. And in randomized controlled trials, endoscopic eradication therapy decreased the risk of progression by 60%. So we're moderately certain of the benefits of endoscopic eradication therapy in the setting of high-grade dysplasia. In low-grade dysplasia, there's about a 10% risk of a missed prevalent cancer. So those patients should certainly still be evaluated by an endoscopist with expertise in Barrett's neoplasia, but the risk of incident cancer is much lower than the high-grade dysplasia, around 1 to 2% per year. So the maximum possible benefit is a lot smaller than high-grade dysplasia. Also, it's not clear from the randomized trials that endoscopic eradication therapy is any better than surveillance for preventing cancer. And even more so, in the available randomized controlled data, almost all the patients with low-grade dysplasia who are undergoing surveillance, who did develop cancer, they were still treatable with endoscopic eradication therapy because they had very early stage cancer. So the benefits are smaller in low-grade dysplasia than in the setting of high-grade dysplasia, and therefore the risks are relatively magnified. Those risks include bleeding and perforation, which are uncommon, but significant, and stricture formation, which is not uncommon, but usually fairly easy to treat. But in particular, patients experience chest pain following endoscopic eradication therapy almost universally. And there's a need for multiple procedures and need for transportation with a chaperone. And then there's still continued surveillance endoscopies after completion of endoscopic eradication therapy. So we felt strongly that endoscopists need to discuss these trade-offs with patients in a clinic setting with adequate time to gauge the patient preferences and to help them decide what's best for their particular situation and their preferences. Also should let you know that there's an ongoing randomized controlled trial in low-grade dysplasia nationally, sponsored by the NIH. It's called SURVENT, SURVENT. If you were to Google SURVENT-BE, Barrett's esophagus, you can find sites that are participating to try to get a better handle on what's our best treatment for patients with low-grade dysplasia, whether we should be performing endoscopic eradication therapy or continuous surveillance. So with focal EMR, we're just removing the area that looks visibly neoplastic, and then we follow that with ablation to get rid of the rest of the Barrett's esophagus. With stepwise radical EMR, we try to remove all the Barrett's either in one setting or multiple settings with endoscopic resection. And there's only one randomized controlled trial comparing the two, plus we found 20 observational studies. We found no difference in eradication of dysplasia or in cancer control between the two, but there were a lot more strictures in patients undergoing stepwise radical EMR. So therefore, we made the recommendation that patients should undergo focal EMR followed by ablation. EMR is typically performed piecemeal, with the largest piece that we can remove is about 15 to 20 millimeters in diameter. ESD aims to remove lesions in block with negative lateral margins. And ESD might also be able to get deeper into the submucosal than EMR for negative deep margins. We did find that ESD was more likely to result in negative margins than EMR. But similar to our comparison of stepwise radical EMR to focal EMR plus ablation, we found no evidence that ESD was superior for control of cancer than EMR. But ESD was associated with greater risk of strictures. This was primarily based on observational studies rather than randomized controlled trials, and there may be differences in what sort of patients were selected for ESD. So it might be that an RCT could show that ESD is better. And there are technical reasons why some lesions might benefit from ESD. So for instance, if the lesion is very bulky, if it's raised and very bulky, it might not fit in the cap for EMR. And also if the lesion is highly suspicious of a T1B lesion, one that's invading the submucosa, so if it's a depressed lesion, for instance, then ESD might be more likely to achieve a negative deep margin. But our guideline also differed from some other prior guidelines, which had set a size limit on which EMR should be used. The thought that trying to remove lesions with one piece with EMR, and that's based on the assumption that you should try to get negative margin. But as I mentioned, we found a striking effect in favor of ESD for achieving negative margins, but it didn't translate into improved cancer control. So it suggests that these negative lateral margins in EMR are not all that relevant if you're performing piecemeal resection with overlapping contiguous pieces. So the vast majority of patients can likely undergo EMR rather than Oh yeah, absolutely. First of all, this guideline is just about endoscopic eradication therapy. We're currently working on a guideline regarding surveillance, and then once we complete that, we'll be working on a guideline for screening. And then probably time to circle back and go back to treatment again because it takes so long to develop these guidelines. In terms of treatment, I'm hoping that we'll have better understanding of how to select patients with low-grade dysplasia for endoscopic eradication therapy, and maybe even some patients with non-dysplastic Barrett's. I'm hoping we'll have more data on comparing ESD and EMR, particularly in high-risk patients. And hopefully we'll get more research telling us how to better control post-endoscopic eradication therapy pain and stricture prevention. And also finally, understanding how best to survey these patients following endoscopic therapy. How often and when can we stop doing endoscopic surveillance?